Good evening. Welcome to today's webinar. Thanks for joining us. I'm Danae Aber. I'm the Healthcare Innovation Supervisor with Well Ahead, Louisiana. Please note that your lines are muted so we can prevent background noise, but feel free to enter questions into the Q&A box at any time. We will probably stop a couple of times during the presentation and try to answer any questions that you have. Today's webinar is the 6th in our series, our Telehealth in Practice webinar series presented by Dr. Ted Hudspeth. And today we're talking about chronic care in telemedicine. If you weren't able to join us on the previous sessions, the recordings are on our website. You can view them at any time. They're listed here. The website is walpen.org/telehealth. And we'll also have some on-demand sessions that'll be posted within the next couple of months, so stay tuned for those. Just in case you are joining us for the first time, I want to make sure that you're aware of the TxLaw Telehealth Resource Center, which is funding this series. TxLaw is a HRSA-funded program at Texas Tech University designed to provide technical assistance and resources to new and existing telehealth programs in both Louisiana and Texas. And they are partnered with us at Well Ahead to serve as the support representative for Louisiana providers. And TxLaw is part of the National Consortium of Telehealth Resource Centers, and you can access their website and all of their resources from resource centers across the country through the consortium website at telehealthresourcecenters.org. And with that, I will hand it off to Dr. Hudspeth.
Well, thank you so much, Danae. I appreciate that. Tonight, we are talking about chronic care management in telemedicine. This is a little bit different than what we had been talking about, where I had really been leading up to talking about how we do everything face-to-face with our patient ourselves. And what I really consider the new and exciting, field of telemedicine, where you're actually delivering your care directly to a patient, just like we do in a room. Well, this is a little bit of a departure. In acute care medicine, we're dealing with a major problem, right now that we've got to deal with. And in our previous series, we've gone not only through how do you lead a patient up to getting into the visit, but how do you do the visit? How do you do the physical? How do you do the documentation? So be sure you go back and look at all of those that are posted on their website, because they really go through a lot of detail. And every single one of those videos has the PowerPoint that is stationed there with it, so you can go through all of that yourself. I'm trying to build all of these presentations to really be a reference for you. So I will fly through these slides a lot, okay? But it's a lot of data, guys. So you need to think about going back and looking at any of these that you have a particular interest in, because there's a lot of stuff there. And I really built them as being like a toolbox for you to go back and get the information later. As you decide to implement this into your practice. So the chronic care management piece of this, the big deal that's different about that is that we are dealing with all of these chronic problems that people have. And actually, before we go into that, did you have any questions from the previous sessions, Danae? I forgot to ask you that.
I don't see any in the chat right now, but we will give it just a second. If you did have a chance to attend or view the recordings of any of the previous sessions and you have any questions, we can go ahead and take care of those now before we jump into new content. So we'll just give it a minute here to see if we get any come in.
Yeah, and while we're doing that and waiting on any questions, just a little bit about myself. I'm from a rural town, Amite, Louisiana. Grew up there, and then graduated from LSU Baton Rouge, go Tigers, and then LSU Medical Center in New Orleans, where I got my medical degree, and then went to LSU Shreveport. So I have been all over the state, and I am back in Hammond, where I have been for 27 years now with Ochsner Health System. So they are who gave me my big break to be able to do all this telemedicine stuff, which has been awesome for me and my patients. So any questions in there, Danae? All right, well, let's move on forward. So I put a quote in here: to start by doing something necessary, then do what's possible, and suddenly you are doing the impossible. So on the doing the things that's necessary, you know, that's all the acute care stuff that we have done historically. My practice started out as much of an acute care practice as an urgent care these days. But as time has gone by, you know, the needs of my patients have become more of a chronic care management type issue. My practice now is mostly chronic care management, and that's in the office. But there are additional ways that we can care for our patients through telemedicine for all of these chronic issues. So the overview of what I'm going to talk about tonight is just what are the chronic diseases, and then what is chronic care management? How are we doing this in a new, unique way through billing codes that Medicare actually provides for? Because so they're encouraging this for some big reasons. You know, it's quality of care and actually reduction of costs, which, you know, is part of the triple aim of being able to improve patients' outcomes and provide better for them over time. Next, we'll go through some of the provider requirements for this, some of the templates that can be used, and coding on how to do this. And I'll have a brief talk about outsourcing. So starting off with the chronic diseases, you know, these are conditions that last a year or more and require ongoing medical attention. They often limit activities of daily living. And, you know, the biggies here are heart disease, cancer, and diabetes, especially in Louisiana. And these all lead to major debility in all of our population. And these are the leading drivers of the $3.8 trillion in annual healthcare costs that our country expends each year. And we all know the biggies, you know, high blood pressure, arthritis, diabetes, CHF, CKD, and you know the list. You've got a ton of folks on these or with these right now. So you can think about how would you maybe implement some of this chronic care management on all of these folks that you already care for, and probably do a lot of the work that I'm going to talk about tonight, but you're probably not getting reimbursed for it in the way that you're doing it now. Our biggest risk factors: tobacco and secondhand smoke, poor nutrition, lack of activity, and excessive alcohol use, all of which are very pervasive in Louisiana. And I'll show you some charts as to where we fit into some of the biggies on this, and it's probably because of some of these reasons. Some of the statistics on the finances are 99% of Medicare spending is on patients who all have chronic conditions. That's pretty reasonable. You understand that. And 7 of the top 10 causes of death in 2014 were from chronic diseases. 6 in 10 adults in the United States have a chronic disease. So when you're starting to think about chronic care management as a platform in your practice, you have a great opportunity to be able to capture a lot of folks and get them into a program such as this. People with chronic care conditions account for about 86% of our national healthcare spending. And sadly, racial and ethnic minorities really have a big part in this. I mean, they suffer from a lot of these chronic illnesses. So that's what leads to some of our disparities in care, especially since many are in the rural areas where they do not have as much access to care. Later in this series, probably into May, we will actually be going through some of these disparities in care. So be looking for that coming up in the future. I pulled some of these links. You actually, at the bottom, you can go to the CMS chronic condition data link. I pulled some biggies here. As you see, you know, I wish red was a great color here, but it's not. Red is a very bad color, and you can see how Louisiana and Texas in many of these photos, with chronic kidney disease on the upper left, diabetes on the upper right, hypertension prevalence on the lower left, and then stroke prevalence on the lower right. We suffer from these a lot in our communities. And so providing a program that could maybe help reduce all of these in our communities would be a huge benefit to achieving a goal of which Warner Thomas from Ochsner has felt that we should be 40 by 30. That's a plan that he's implemented where he's doing putting a lot of programs in place to try and help our population go from where we're the 50th in the nation with some of our health issues to 40th by 2030. So that's an audacious goal, and I'm doing everything I can to help out with that, and I know you are too. So our expenditures here, 90% of the nation's $3.8 trillion in healthcare spending costs are from people with chronic and mental health conditions. So Danae has a poll here. Knowing what these chronic conditions are, can you give us that poll? So I'll let you guys answer that, and I guess later we'll go through that and see what the numbers are. There we go. So let's go through and discuss what is chronic care management, because it can mean different things to different people. Actually, back in 2015, CMS came up with some new billing codes that they would pay for chronic care management. And basically, physicians are reimbursed for the extra work that is put in with trying to help manage people, mostly over the telephone. So when we say telehealth, it really is a lot of times telephone, okay? And this allows our staff to be able to participate in this and pretty much do the bulk of the information gathering with the oversight of the physician. And this is really intended by CMS to help keep people out of the hospital. You know, for CMS, that's probably one of their big ticket items, is having people go into the hospital. So the thought here is that the physicians and their offices would be paid a little extra to be able to help people stay healthy. Well, that's why we went to medical school, guys. You know, so this is great. You're being paid to help people remain healthy and not just be in the sickness business, which I think we all would like some of that in our practice. So this is a flyer that they initially came out with called the Connected Care flyer, where they talked about putting out these codes. And basically, physicians can participate in this. Certified nurse midwives can be a part of this, and clinical nurse specialists can bill for this. Nurse practitioners and physician's assistants can all participate in this. So those are the practitioner eligibilities. And for a patient to be eligible, they must have 2 or more chronic conditions that are expected to last at least 12 months or until their death. And it's also a criteria that these conditions place the patient at a significant risk of death or having some acute decompensation that would actually put them into the hospital, okay? Now, Danae was telling me right before this, there are some new codes called, actually it's a system called Principal Care Management. And Danae, you said that was really when people have one serious medical condition. Tell me about that one.
Yeah, so principal care management is very similar to chronic care management. So a lot of the things that you're going to talk about apply in the requirements and those things. But the biggest difference is that it is for management of one high risk disease, rather than requiring 2 or more chronic conditions. So the condition has to last at least 3 months, or put them at risk of hospitalization, or is unusually complex due to comorbidities. Those are the requirements.
Yeah, so again, you know, CMS is doing everything to try and reduce that big ticket item, which is hospitalization. And again, I love it because it's keeping people healthy, which is awesome. So they have to do, or this usually stems from some initiation visit. So when they're seeing a provider for their physical exam, you know, in their regular E&M visit, then this can be initiated over the next year. So as far as provider requirements, there are some things that you have to be able to provide to be a part of this. You have to be able to have a recording of their demographics, problems, medications and allergies. And then you also have to be able to have that in a certified EHR. Okay, so if you're online or if you're doing a regular health record or health maintenance record, you could probably do all that part. And then you have to keep up with a full list of problems and the medications as they change and their allergies as they change. And you must be able to have that care plan and care coordination and the documentation of all that as you go on through the year. The patient needs to have a 24/7 access and continuity with their providers. Many of us take call. We're on call on the weekends and at night. So they want a patient to be able to have that access to, again, prevent them from going to the emergency room, because that's where so many costs occur in that population. And the continuity of care, obviously, is to be able to follow up problems over time and make sure that they are being managed and not just left out there without good management. As far as the conditions, the systematic assessment of patients' medical, functional, and psychological needs are really something that the nurses do. They can do the PHQ-9 and things like that, that they can assess patients' needs, what their functions are. Do they use a cane, wheelchair? How do they get to the office or the hospital, and those kinds of things. So they start documenting all of those things in a systematic way. And of course, medication reconciliation is where probably I would bet most of our errors occur in the medical management of patients. And having this is a really big deal to reducing some of your own malpractice if you're paying a huge amount of attention to this and your staff is doing the same thing. And of course, management or oversight of when medications are changed and making sure that the patients are taking their medications correctly is important. And that's a big part of it. So you basically kind of keep up with all of those things over time. You put them in an electronic medical record where everyone on the team has easy access and allows you to be able to share that data electronically. That's kind of the gist of all of this. And then you end up providing the patient with a copy of that. So if a patient ends up landing in the emergency room or going to another outside physician who doesn't have access to your records, then this comprehensive care plan is what they have to be able to help them along. And your job is, as a provider and your team, is to be able to put all of that together in a cohesive manner. Okay. So just the bullet lists on what this includes, you've got your problem list, your prognosis on those problems, measurable treatment goals. So the nursing team usually goes through goals that the patient should try to achieve and also works with them on how to achieve those goals. There's symptom management. So if people are having a lot of symptoms with their various diseases like shortness of breath with CHF, they try to minimize those symptoms. They plan interventions and they identify groups of folks or providers that can help them with whatever interventions that they're needing. Again, I talked about medicine management, and then they try to plug in community and social groups to be able to help where needs exist. And a lot of times that can help mitigate people going into the emergency room or into the hospital. They try to teach patients actually how these services and agencies can help them. And then they schedule them for periodic reviews. So the nursing team does that oftentimes on a monthly basis because that's how your billing actually goes. Many of us are doing TCC visits in our offices. Those are specific visits where when a patient gets out of the hospital, you try to schedule them within so many days to be able to make sure that they've gotten the medicines that the doctor in the hospital wanted them to take, or follow up on labs or tests that were still pending when the patient left. And also to make sure that the patient knows and has scheduled any other follow-ups with any specialists that they were supposed to get with after their hospitalization. So in this transition of care, that again is another place where a lot of patients fall through the cracks because they just don't get the things that they should have, either through misunderstandings or not getting booked and not having the resources that they need. So again, this program allows you to be able to plug them in where they need to be to maintain good health. Working with home and community-based care organizations is a really neat thing. We're usually not paid for doing this kind of stuff, but in this program, when your team is reaching out to community-based groups that offer services, that's a huge help for those in need. Many people don't have family members that can assist them, but there are many groups out there like churches, et cetera, that actually help with people in the community. And you can help tie that knot together for the patient and connect them. Of course, when you get started, the patient has to consent for this. There is a fee for it, which 80% of that is actually paid for by Medicare and 20% by the patient. So they need to understand what they would be getting for that. But when they understand the level of, I guess, attention that is paid to their problems, it's really an easy go of it for them. I wanted to go through this next slide. There was a great video that I found, and I'm going to see if I can play that because it's actually a testimonial about one physician's experience. So let me know if you can't hear it, Danae.
Rayford is a typical rural North Carolina community. We never know what we're going to encounter. We can spend hours of care beyond face-to-face interactions, yet we were not being paid for those services. We did know that we had to do something different. At last, the chronic care management program had a way to capture those events of care documented and actually be paid for it.
With chronic care management, patients don't feel like they're alone anymore. They feel like they have that extra person that they can trust. Their health is in good hands.
We are changing our interactions, reaching out into the home of the patient via the portal, via the telephone, engaging people in their own care and assisting them in making proper judgment calls about serious conditions.
There's a lot of damage that I had from being in the military and in the war in Vietnam. The chronic care management that I received was something that I needed in order for me to maintain my health.
In my group, I can actually compare those who are participating, those who are not. This truly has benefit in terms of outcome. By reaching out to the patient and getting a sense of what's occurring on their own well-being, we're able to intervene before it escalates. So if we shift in our behavior in providing care for people who have chronic conditions, we actually have an impact in terms of the healthcare costs for the entire community. My love of medicine comes from the interactions with people. If I can do my part as a physician, enhancing the care of an individual, that's pretty special. That's my motivation.
I just thought that this was an awesome video because, I mean, first of all, she says, whoops, I'm sorry. Let me get past that. Sorry about that. She says in 2 minutes what, you know, my passion on this is going to say in an hour. Think about what she said there. She can tell the difference between those people who are in the program and not as far as their outcomes. So, you know, many of us are in or will be going into value-based contracts in the future. That is really how Medicare is going to pay all of us in the not too distant future. Okay. So it's rapidly moving towards that. And basically they're going to be paying you to take care of people and keep them healthy. Okay. We're moving as a country away from the sickness business, and we need to be moving toward the wellness business. Okay. And so we're all going to be paid based on value-based metrics. Well, this program is going to pay you additionally, really, to move patients into methods or give them tools to be able to remain healthy. That's a win-win. And so if you're thinking about the future of your practice and where it's going to be in, say, 2 to 5 years, you need to be thinking about how are you going to manage these chronic care patients. And to me, this is something that is already available. They're already paying for it, and they actually have a lot of tools online to be able to help you. Okay. So I'm going to go through some of those pretty rapidly here on these templates. Okay. I built them out like other folks that I saw had a lot of these. It's like a big long one pager on, or multi-pager on everything that needs to be documented. And I'm going to piece apart each one of these little templates and just show you what I'm talking about. So the shared care plan is free to the patient, obviously. It's a personal health record that allows the patient to keep track of all of their vital health information, okay? And then they have a copy of it. And this can be shared with other team members that also care for the patient. The major sections that they have are the general information, the care team, the information about me, that's about the patient, their diagnoses, the next steps that they should be taking to remain healthy. And that goes through all of their concerns that they have personally about their health, their goals for their health, and then the actual steps that the teams, the healthcare teams, go through to help them achieve those goals and mitigate those concerns. I mean, that's a really nice thing. We should be doing that in our regular practice, okay? But we don't have time a lot of times when we're taking care of an illness. But this program would help tie in your staff to be able to help patients achieve those things. There's a health log on things like their A1Cs and such as that, their medication list, allergies, and histories. Now, if you take a snapshot of all of this, much of this, if you're already on an electronic health record, you've already got all of this information. So that can be pulled easily into your documents. So we're going to go through that first one, the general health information. I saw some practices even have some of this online. So I put the www.yourclinicwebsite.com where patients could go in and they can log in and see their health record on this, okay? That would obviously have to be a HIPAA compliant, accessible tool, but many health records allow that. I know our health record, we use Epic, and patients are able to log in and see their health information, so they could see that. And it's just a way to make it so that even if they end up in an emergency room or somewhere else, people can log in and see that information if they need to. There's critical information about what would they do in an emergency. So they think about ahead of time what they would do, and they put this on the document, okay? And that's when it's on the document, even if they can't communicate, that could be had by their caretakers with them when they go to the emergency room. So everything will be in one place at one time. The patient actually can fill out a lot of that information ahead of time, and then they bring that to all of their visits. They can share that with other team members from their paperwork. So if they went to their cardiologist, they could do that. And then they work together to define all of the problems with all of their healthcare members, and then actually have the healthcare members, if they go somewhere else, they can put that information on there to bring that back to our teams in our clinics. They have advanced directives on there. So like their living will and their decisions about life-sustaining treatment, which these are things we should be doing all the time anyway, but many times that's not done. And this is an ordered way to get all of that documented ahead of time, which is a very good thing to do. And then, of course, having the discussion about power of attorney, which is often a delicate subject for many, but this document is one that you can use to do that. In the documentation, you always put who's on the care team. So list out their cardiologist or their pulmonologist and who works with them in the clinic, et cetera. So all of that's in one place. We go back and we put appointments on there so that the patient will know when their next appointment with different doctors is. We go through and list out their insurance providers. Many times people lose their cards, et cetera, but if it's on this plan, they'll have that if they end up someplace besides our own clinics, if they have to be seen. And in the about section, this is kind of an open area where the patient talks about the most important information about me. That's kind of an open-ended question, which is awesome. It allows them to express some of their own concerns and what they want to share with everyone. They go through and talk about their own challenges with their vision and their hearing, speech, mobility, and their transportation. It can be filled in there. If they have, if they're bilingual or prefer other languages, they list that on there. If they know their blood types, we can put that in. Of course, any special diets that they're on, we document that. Spirituality and their religiousness, that's something that we put in that. And on this particular one, we have all of the advanced directives and all that in one spot. We talk about who they live with, their home situation, and then how they best learn. A lot of these things are things that we're collecting in our electronic medical record now to be able to know, what impedes a patient's ability to be cared for. And it just allows us to be able to take a snapshot of that when we have this filled out. This is a question about, do they have access to the internet? We can't do telemedicine visits if patients don't have some access to that, but if they do, we have another way to reach out to them. In these documents, we keep up with all of their diagnoses, the description, the date, and who diagnosed that if we have that information. And then the next steps. This is a neat area where your staff can start educating the patient, document that in one place, but it formalizes, what steps the patient should take to remain healthy. And in that video that I showed, one of the people were talking about how they feel like they're able to get the patient involved in their care. And this is a method to do that. That's a big part of what CMS wants the patient to do, is become involved in their care. And organizing all the information in one place and making a care plan for them is what allows them to do that, okay? So the next steps, they can talk about their life goals, and we can sign off on when they've completed some of those. And these are actually the steps that they're to take and the actions that they took. So each month when our teams follow up with them, they can discuss these and see what they've done. And it's a place where you can just reiterate what they need to be doing, pat them on the back if they've achieved some successes, and to keep them going, keep them motivated. So as far as your staff, you kind of have to help your staff learn these things. So this is something you'll have to educate yourself on, share with your teams, but you'll have to allow them to teach some of these self-management tools. So, things like diet and exercise recommendations, that's something that you kind of have to work with your teams to teach them first, so then they can teach what you want the patients to learn later. It's best to test those tools on a few patients, oversee how your staff is actually managing the patients with that, and then you can set them free and they'll go to town with it. Some of the staff are more comfortable with this than others, but again, sharing your philosophy with the team and how you like your patients to be taught these things is pretty important. And it'll put your own flavor or flair on your practice and what you want to espouse to them. And usually this is set up into a 15 or 20-minute audio visit, usually over the telephone, where the nursing teams go in and they teach these things and talk with them. And you kind of have to have some scripting to this, because you could get into some pretty long conversations at times, but having appropriate scripts will help your teams be able to get it all done in an appropriate amount of time. Again, they work with the patients to define their goals, and they include family members. Just like right now, I've been trying to get a lot of patients on our electronic portal. This is a great tool too, to be able to talk about, well, who's helping you with your care right now? Would you mind if I speak with them and involve them in this, so that they can know what you want, know what you're supposed to do, and then help you achieve those goals? So this is a great tool to be able to break the ice on those subjects. We do document goal setting in our registry, actually. So that's they have to set a goal and then try to achieve that each month. And so that's why they look forward to doing this each month. On the health log, this is again stuff that you're already collecting yourself. Their A1Cs, their blood pressures, cholesterol levels, and stuff like that. So you're already collecting this data and can plug it into the health log when you're building your templates. Medications, you already have all of these. the big point on this is just reconciliation and making sure that every month that we have an accurate list of medicines and or non-prescribed medicines like vitamins. This is just a list showing you one suggestion where you can actually, on their paper, you can put whether they're to take each medication at breakfast, lunch, dinner, or at nighttime. So, and this is an additional medicine page. So if they are taking a vitamin or something or an herbal supplement, you can list those out in a separate section. And then discontinuance of medications. How many times have you had a patient get off of a medication? You thought they were getting off medication, but they're still taking it. So this is one place where you can have that information placed so that they can always reference back and say, oh, I'm not supposed to be on that. Allergies, of course, we all have access to that. And then contraindications to certain things that they shouldn't be on. This is kind of like an allergy list, but specifically things that they've had troubles with in the past and not a true allergic reaction. In the history section, this is more to document things like hospitalizations or surgeries, you know, some of the bigger items that you put on your list. So this is just kind of procedures and surgeries area. And then any hospitalizations if they've had some, so you can kind of keep up with the numbers that they've had and actually see what they were admitted for. So in the future, you'll be able to try to mitigate those problems or focus on those problems so that they don't have issues. The immunization section, that's something that we all keep up with too and have access to. So before I go into the coding pieces, I saw a few questions maybe pop up. Danae, do you have those?
Yes, one was actually a coding question related to principal care management. So I don't know if you want to do that now or after the coding section.
Go ahead. If you have some information, go ahead and do that.
Yeah, someone just asked if we could provide the codes for principal care management. So I did send those, but I'll say them out loud for anybody who might be on the phone. It's G2064 and G2065, and that's for one is for non-physician practitioner and one is for physicians, and those are in 30-minute increments. And then RHCs and FQHCs actually bill under the same code as they would bill for chronic care management. Which is the G0511. But it's important to know that RHCs and FQHCs do not qualify for principal care management until dates of service beginning January 1 of this year. So that rule became effective for those providers January 1.
Okay.
And then someone said they tried to go to the yourclinicwebsite.com and it didn't go anywhere.
Yeah, that's not a link. That was your clinic. Okay. So I just put that, whatever your clinic's website is. Okay. That's what that was for. I'm sorry. So that was it.
That's it. That's what I've got.
All right. Good deal. Good deal. All right. So when you're coding, you're basically going through non-complex versus complex chronic care management. So the non-complex ones, they differ in the amount of time basically that you're doing, and of course the amount that you're dealing with. So as far as the similarities, there's a reference here to some of the other pages that we've gone through, and these you can just click back on the links and see those things. So these are all different slides that you have to do for the non-complex and the complex. We do the same thing on this level, okay? And next I'm going to go through some of the differences, okay? So on the differences, chronic care management services of at least 20 minutes of staff time is this non-complex 99490, okay? So you're doing 20 minutes of time. You're dealing with 2 or more chronic conditions expected to last 12 months. And the chronic conditions place the patient at significant risk of death, acute exacerbation, decompensation, or functional decline. And the comprehensive care plan is established, implemented, revised, or monitored, assuming 15 minutes of work by the billing practitioner per month. So part of this is your staff getting this information, and part of it is you actually going through all of that and making sure that everything is appropriate. The link below is actually to look at the physician fee schedule for that. The next one is, again, non-complex 99491. This is where you provide, personally by a physician or other qualified health professional, at least 30 minutes of physician or other qualified healthcare professional time per calendar month with the following requirements. And again, it's the 2 or more chronic conditions, placing them at significant risk of death or decompensation, and a care plan is established, implemented, revised, etc. Okay, so the difference here is time. Okay, 20 minutes versus 30 minutes of time. And then going into the complex, on this complex chronic care management services have the following elements. Again, it's chronic conditions that last at least 12 months, and the conditions place the patient at significant death or decompensation. And going down, it's the 60 minutes of clinical staff time directed by the physician or other qualified health professional. So it's a lot more time, and it's moderate or highly complex issues that you're dealing with. So, and there's a link to the physician fee schedule there also. And there are some other things when you're doing additional 30 minutes of time, et cetera. There are some other caveats where you can plug in some of these other codes. Okay. Those would probably be pretty rarely used. And that's the same thing with these special instructions. So I pulled one provider's experience that was doing this. They looked at, first of all, I think the average was around a $42 per patient per month fee. And again, there's regional variation with that. But they went through and looked at all of the time that they spent, and they did their health coaching over the phone or secure email, and did all their care coordination referrals and the services that were provided by all of their people in their clinic. Okay. And when they did all of that, they had 2,500 patients. 30% of that population was Medicare. So that was 750 patients. 70% of that would come down to that are actually fee for service, because on this particular clinic, some of their patients were already on a value-based contract. So the 70% were fee for service. So that left them with 525 patients. Of that, 70% of those had 2 or more chronic conditions that would fit in the qualifications of what I presented earlier. So that brought them down to 368. They estimated about 75% of patients would consent to participate in this type of program. So that left them with 276 patients. And if they billed at a $42 per month of those 276, that was $11,596 per month, with a total of an annualized $139 and $104. Sorry about that. Can't even say those big numbers anymore. So that's a pretty significant chunk to a practice. Now, obviously, there are costs associated with this, but there are costs associated with doing a lot of this work that your nurses and entire team are already doing. And, it usually, the math usually works out to where there is a surplus here, to value your time also. It's all kind of baked into that. I think for those of you who are now or are going to value-based care in the future, this would have exponential benefits to you in making your value-based patients healthier. And in a value-based system, you are going to financially do better. Your patients are going to be healthier. And I promise you, you will be more engaged and happier if that's what's happening on both ends. We all went to school to be good providers and help people. And this incentivizes everyone along those same lines, which is great. So as far as chronic care management providers, there's actually an investment in technology. So many of us already have that. There aren't many people who aren't using an EHR these days. Okay. And, some of this can actually be outsourced. I did want to talk about that. There are other companies that can actually do this for you and help you with your patients. So If your ultimate goal is just to get a better value metric on your patient population, then you can actually have some of this outsourced, to them. There are many companies that do this now, and actually we're using one of those right now. So it's been a good thing for us and our patients in our practice, and I highly encourage you to look at that. I put in a few resources here. There are some chronic disease data downloads you can go and look at. That's where I pulled some of this data earlier from with the disease incidents across our country. But you can drill this down to your zip code even and find out some of the diseases that are more prevalent in your area. So that might be a way for you to start looking at, should I provide more services in mental health in my clinic, or for people with chronic kidney disease or hypertension management. You can go and start looking down to the zip code level, which I thought was pretty neat and may help you out. And these are some other things from CMS, their Connected Care Toolkit. It's excellent, and was actually a great reference for me for this lecture to provide some of that detailed information for you tonight. So you can go and look at that. And we have other resources. These are some of the resources that we've been having ongoing for this series, and you can go back and reference some of those things. Certainly all of these videos and the handouts and references that we are using are posted on the walpen.org/telehealth page. So write that down and keep that so that you can go back and reference some of this information later. So let's open it up for questions.
We do have one here in the chat. Any idea how much Medicare pays for once a month CCM code, which I think they put in right before you kind of got to that slide?
Okay. All right. Yeah, we went through that in the slides. And I actually had the reference to the billing tool and the estimated payment tool. That's all directly from CMS. So you can go in and look specifically at what you would be able to get.
And then I will say too, for RHCs and FQHCs, it's a little different. The payment is, last I looked at it, was $66.77
Wow.
For RHCs and FQHCs. It's a little higher because the way that they're paid.
Right.
And then the second part of their question was, what if the patient does not want to pay their copay?
I don't know the answer to that. Probably the next month they would not be eligible, I would assume. That's going to be just if they didn't pay their copay for their visit in your office. How would you handle that, and what do you do? So, that's going to be up to you, I would think, as a provider.
While we're waiting for more questions to come in, I'm going to go ahead and show these poll results. So it looks like about half are doing it and half are not.
Okay. Well, good. Well, I appreciate everyone participating in the poll. Actually, while people are thinking about questions, I'd like to ask if anyone would like to ask a question about any of our previous ones, or even off the cuff. It has nothing to do with any of them, but as long as it has something to do with telemedicine, feel free to ask. I'd love to hear your questions.
Not seeing anything coming through, but I'm keeping an eye on it here.
Okay. Well, I again want to thank you guys for everything that you are doing to pull this together. In my discussions with Danae, she said not everyone around the country is doing the things that they're doing as organized as they are, to be able to provide this type of information to folks who are interested in implementing telemedicine in their practice. I'm so passionate about this because I truly believe we are going to reach so many folks through telemedicine. There's currently a push to allow or improve broadband across the country. We're going to have more broadband services in rural areas that do not have that now. And when broadband right now is really almost like having electricity and water. It's critical to be able to do anything today in our society. So I think the government is stepping in, and those changes will come. I do believe that we will have broadband everywhere. And when that happens, you will have access to your patients and being able to care for them even more than you do now with a telephone for those who can't reach us now. So I encourage you to get on the bandwagon now. Start small, but plan to go big, because it will be.
Yeah, and I know that at the state level, they're doing a lot with broadband as well. That's a big priority in the governor's office. And there was recently a lot of grant dollars that are coming down to the state level to get broadband out to rural areas. So we should be seeing some movement on that pretty soon around here. So.
Yes, I am, and again, we use Epic where I work, and they do have an excellent portal, the patient portal. So there's an app the patient can get in. They can ask me questions, medicine refills. They do their telemedicine visits through that app, et cetera. And how I've really positioned it with people, I've told patients, it's like having Dr. Ted in your back pocket. Okay, so I've told them all that. And I use that saying a lot, but it's true. And that's how people kind of feel about it. When they have a problem, they know they can reach there, and I want them to reach there. I don't want them to reach out elsewhere and get fragmented care in some urgent care somewhere where they don't even know their medicine list or their problem list. I want them to be able to communicate with me. And I believe that, telemedicine provides me a way to do that.
We do have another question. I'm assuming this is referring to chronic care management. Do you have to be a PCP to be a part of the program, or can you be a specialist with a nurse practitioner helping?
My understanding is any physician can participate in that. So you don't have to be a PCP to do that. As long as you're providing all of the points in there, in everything that I found, I did not find anything that said you had to be just a primary care physician. So you do have to provide all of those documented points that we went through, though.
Yeah, I think there has to be, I'm glancing through some guidance that I have up on my other screen for chronic care management. I think there has to be an initiating visit with a primary care physician, but it doesn't, they have to be referred by a primary care provider, I think.
Okay.
But the person who's providing the chronic care management services doesn't necessarily have to be a primary care provider, I don't think.
Mm-hmm. Yeah, in my own institution, I do have to sign them, but we actually outsource those services, and that is cared for outside of me. I don't have to do those. Can if I want to, but I don't have to do that. So it would allow anyone to participate in that.
All right, that's all I'm seeing so far.
All right. Well, we'll see everyone in 2 weeks.
Yes, so the next session is on April 8th, and we're going to be talking about marketing your telemedicine practice. So we're excited about that. As you exit the session, you'll get a pop-up probably in your browser that'll ask you about future topics. So we're still finalizing the list for May and June. So be sure to put any topic suggestions that you might have in that one little survey question that we have. And we will be deciding on those last topics in the very near future. And I think that is all that we have for you this evening. So thank you so much for joining us, and have a great night.
Thank you.